It was kind of a surprise, but obviously a very gratifying one to be recognized in some way. But really, when you look at the other names in the history, I was definitely pleasantly surprised. Sure. And unfortunately, the meeting conflicts with my daughter's college graduation, so I won't be there in person. But the lecture is on a subject that I delve into a lot, but it's on cardiovascular disease in the setting of end-stage kidney disease, dialysis in particular. And really an overview, so a little bit about the scope of the problem and the epidemiology of how patients on dialysis really have devastating levels of cardiovascular morbidity and mortality, a little bit about the unique pathophysiology of cardiovascular disease in that setting. And then lastly, I go into some of the treatments that haven't really been so helpful and the evidence for that, and maybe some emerging opportunities. Oh, I could give you a little bit about both. I think the really the study that's been probably the most gratifying for me was really twofold. One, actually not in dialysis, but the first one being the modern dialysis study, which was a study designed to really take advantage of the loop recorder technology that had been developed in the previous years to allow really long-term monitoring of patients in dialysis, and it was really one of the first studies to get a handle on. We know patients on dialysis die at extraordinarily high rates of sudden cardiovascular death, but no one had really been able to monitor people for more than a couple of days at a time to get a sense of what, whether those were really arrhythmic deaths, what the rate of arrhythmia was, what kind of arrhythmias people were having. And so that was a small study, but in its way, sort of a landmark study to really define the incidence of serious arrhythmias in this population and the relationship to the dialysis population. Sorry, the dialysis procedure. I think the second study, I was very lucky to be part of the steering committee for the Credence trial, which was one of, really probably a landmark study, first of its kind to demonstrate that SGLT2 inhibitors could actually slow down the rate of kidney disease progression and prevent dialysis. There would have been some data to suggest that was true beforehand, but that was the first dedicated kidney study with primary endpoints of kidney disease progression. And to be a part of that was really, I was certainly not the senior, the last author, but I was part of the steering committee, and really, I was really happy to be part of such an important study that's really kind of changed how we practiced. I'd say, in terms of hurdles, probably a couple of things. One, just like everyone, it's always a struggle to get NIH funding. I've been pretty successful, but that doesn't mean it's easy. I think on a more granular level, at times, for those of us who are really interested in trying to do better for patients on dialysis and study and do trials or investigations in folks on dialysis, at times it's been hard creating partnerships with the dialysis chains in the ways that we would like. And I had a particular situation when I was still in Boston that was particularly frustrating, lasting for months or years, where we had a great study we were trying to do, but couldn't couldn't find a way of getting it done in the dialysis unit. So I think that's a challenge for many of us in the field, is this nexus of trying to do your academic and research thing and figure out how to make that work. In the setting of these generally for-profit units that are, not usually part of the same system as the person doing the investigation. Sure. Quite a few things. A major project we're working on right now is the HOPE study. That's nearly done, but that was an NIH multi-center network trial to investigate ways of treating pain and to a lesser extent opioid dependence in the dialysis population. It turned out nephrologists have done a pretty good job of reducing the opioid use in dialysis populations. It's mostly focused on pain. And that study, I think the results will be available relatively soon. So that's been a major project for the last couple of years, a little bit different than the kind of thing I usually work in terms of not being a cardiovascular focused study. Two other things I'm currently working on include a study trying to get a better understanding of this entity called myocardial stunning in the dialysis population. So there's been a lot of data over the years to suggest that when people get onto dialysis, they have the onset of reversible dysfunction of the heart. So reversible wall motion abnormalities in the left ventricle, and that these go away after dialysis and is purported to be a signal of recurrent injury that happens to heart and dialysis and may underlie cardiovascular disease. So we had some questions about that, whether the reported incidence was really correct, and does it recur on multiple sessions, and what's the underlying etiology. So we've been for the last couple of years doing echocardiograms on individuals who are on dialysis, both at the beginning and then at the end of a session, and doing some related physiologic studies to try to get at the underlying etiology of this entity. So that's, and then more recently, we've started a pilot trial of an SGLT2 inhibitor study, drug I mentioned earlier, to understand in a pilot way whether there might be a signal of physiological effects that could ultimately translate into a benefit if we were to use these longer term in the dialysis population. Where the reasons to believe that they might or might not work in patients on dialysis, since their primary mechanism of action was felt to be an effect on excretion of glucose in the distal renal tubules, which is less effective in patients on dialysis. So those are, I think, three major projects we're working on. I've got a whole bunch of other sidelines, but those are probably the three biggest things right now.